Is my voice okay?
Perfect.
Great. Thank. Aha. So I believe you're doing well. The urinary system. Let me start the recording so that we can. Let me start the recording. Give it one stop. Great. It's our window. The mate, and then you share the screen. Great. Nice. A quick question. Which which organs constitute of this system? And please, if I ask any question, just unmute and speak because I cannot see um, the chat box. I'm sharing my screen. So you'll really do me good if you just respond to me as soon as I ask my questions. Yeah, that will really help me to know how we are uh, proceeding. That is. So, which organs consist of the urinary tract system? You can just mention one, two, or three.
Urethra.
Yeah, so we have the urethra. That is number one. Mention any organ of this system. Yes, guys, are we together? I believe this should be one of the simplest systems. So we have the urethra, which actually eliminates urine. That is its main purpose. Urine and also, of course, a transport tube, sort of that. So we have the urethra. Before I go to the objectives, I need two more answers. Need two more answers. Well, so our
The
objective,
bladder.
yeah, the bladder. Thank you so much. So the bladder, and someone also talked about the urethra. We'll do this in details. This is the learning objectives tonight. We are going to list and describe the functions of the kidneys, actually as one of the major organ of the urinary tract. Describe the gross and the microscopic anatomy of the kidneys. List the main blood vessels associated with the kidneys. And then we are going to define the terms glomerular, filtration, renal, threshold, polyuria, polydipsia, urolithiasis, and uremia. This is actually, we're going to appreciate the whole urinary tract, but of the most essence, we'll talk about the kidneys in a little bit more depth. So we are going to describe the production of urine, how urine is produced, and how this is actually regulated to maintenance of our body pressure and also our body homeostatic mechanism. Also going to describe the mechanism that affect the urine volume, describe the structure and function of the ureter and the urinary bladder. It's also we're going to talk about other urinary tract system organs like the ureters, urinary bladder, the urethra, as you've been able to say. So having said that, this is actually the anatomical presentation or orientation rather, of the urinary tract system. So that we are starting with the kidneys. So we have the right and the left kidneys. Of course, you can see them. The kidneys are bean shaped. And so, referring to the doctrine of signature, most of the foods that are bean shaped are very good for the kidney. A good example is beans of any kind, just because beans have a control amount of electrolytes. There's no electrolyte imbalancing in beans. Think about Brazil nuts, think about think about corrosion, inaitwa cashew nuts, and such. We are not talking about this today, but parts of the urinary system include two kidneys, two ureters, urinary bladder, and urethra. And you can see them here. We have the right and the left kidney, uh, right ureter and the left ureter. Then we have the urinary bladder, and also we have the urethra. So it's as simple as this. That the process of
Wow. Excuse your slide is not. It's on the first slide.
oh well, thank you so much for the feedback. Oh, yeah, yeah, yeah. I thank you. I really appreciate that you noted it before we proceed. What about now? Is it moving?
Yes, yes, it's moving.
Yeah, so this is where I was, this is what I was explaining. That your urinary system consists of the two kidneys, the two ureters, the urinary bladder, and also the urethra. Basically, the process of urine formation in layman's language takes place in the kidneys, inaitwa ultrafiltration. So what happens is that that process of balancing electrolytes, and when I talk of electrolytes, I am talking of sodium, I'm talking of chlorine, I'm talking of phosphorus, and all that are actually balanced in the kidneys. I mean, the ultrafiltration, the reabsorption of water, and also balancing the metabolic electrolytes takes place in the kidneys. So it's in the kidneys where excess water is actually being excreted. It's from the kidney where excess electrolytes are actually being excreted. And let me give you an example. When we are talking about hypertension, we say that we need a diuretic for someone having hypertension. Why did we need diuretic? Because for anyone having hypertension, we are always targeting at lowering the blood and the cellular sodium. Tunajaribu kupunguza sodium level in the body. And so when you give a diuretic, the water and the electrolyte excretion will actually increase. And alternatively, we say that we give Himalayan salt, which have about 84 minerals, which are able to balance sodium. So I'm trying to say that it's from the left and the right kidneys that electrolytes are being balanced from. Then, of course, the waste goes to the urinary bladder and then excreted. Now, there are indicators to tell you that you're not doing well in your excretory condition. I mean, from the kidney, from the kidneys, and we'll talk about this. But I believe I'd also talked about the signs of dehydration, like colored urine. It may be yellow, it may be a little bit dark or brown, and all that. That actually tells you that you're becoming dehydrated in the sense that the body is trying to minimize water loss so that it is able to retain more water. It means you do not have enough water. Or such can happen in cases like hematuria, where there's blood in the urine, or where there's an infection. So we'll talk about this tomorrow, Thursday, sorry. So kidney functions. Number one, maintains homeostasis. Homeostasis is a general optimal body condition. For example, if I say that your blood pressure should be around 120, plus or minus 20, so that if the ideal blood pressure is 120, so if it goes to 130, it is the kidney which is supposed to help, one of the organs is supposed to help in maintaining it back or returning it back through different mechanisms like filtration, reabsorption, secretions, fluid balance, acid-base balance regulation, and production of hormones. In simple terms, I'm trying to say that the liver is responsible to maintain a normal, optimal body condition. So filtration, that is a filtering of toxins and excesses. Reabsorption, that is where the body reabsorbs um, sodium, chloride, water, sodium, chlorine, water, and such. And then we have secretions, and then fluid balance regulation, acid-base balance regulation, and also production of hormone. One of the hormones produced in the kidney is called erythropoietin hormone. Erythropoietin hormone is a hormone responsible for the production of the red blood cells. The red blood cells. So that is where the production of hormones comes about. Let's proceed. Um, I will not really, I will not really disturb you guys
There
with
is
a lot of
there is
yes.
a background noise. I think it's somebody who was not muted. Yes, yes, now.
Can can kindly make sure you mute. Is it okay now?
It's yes, it is okay now.
Thank you. Thank you for the feedback. If there's anything, just be quick to react, because I think today we'll cover quite a lot of things in one class. So just to save time, let's proceed. I was saying that I will not really disturb you to know what dorsolateral or whatever those hard medical terms. But if you see me skip any slide, just know that it's not very important for this class. But I will send you the notes so that you can actually go through them. So let's proceed. This is the anatomical position or anatomical orientation of the kidney, where I have said that one kidney or a kidney is a bean-shaped organ with this of course this orientation. It has a supply of oxygen of blood, sorry, from the lungs, and this happens from the renal artery. I mean, blood comes from the lungs to the kidney through the renal artery, and also the renal vein now removes blood from the kidneys to the back to the lungs, not the lungs, sorry, back to the heart. It's actually the heart, not the lungs. And so it is this blood that is actually purified. It is this blood that goes through a process of ultrafiltration. And hence, there is a ureter down here, which literally takes the waste now to the bladder. To the bladder. This is the bladder which we had, urinary bladder. This is not a simple process as we can actually see, but it's a little bit complicated, and you can go and look or dig deep into how of this process, into the how of this process. So generally, we have the where we have the ureter, we have the renal cortex, that is actually the outer part of it, and then we have the renal medulla, that is actually the fibrous part of your kidney cells, and then we have the renal pelvis, that is actually the the fibrous part, no, not the fibrous part, but the cartilaginous part of it. Let's proceed. So we have the renal cortex, which I said is actually the outer portion of the kidney. It's actually clear here. That is the congenital cortex. Then the renal medulla, that is now the inner portion around the renal pelvis. And the renal pelvis is actually around this place. Around this place. Now, I will not talk about the calyx because this is now more details. Let's proceed. This is the microscopic anatomy of the kidney, where in the kidney nephrons, a nephron is just a basic functional unit of the kidney. In Amanisha, this is actually like a cell, one cell of the kidney, known as nephron. So it has a lot of nephrons. The kidney has a lot of nephrons from which the process of ultrafiltration takes place. This is the process of filtering. This is the process of filtering, um, filtering waste, and also reabsorption and all that. So in the nini, I am sure. Just a minute. Just a minute. Great. Just a minute. Okay, nice. I've seen the scope of what I should have. Now let's now discuss more into let's discuss more into the the nephrons. Now, if you look at the nephron, just look at the picture. I believe I should be able to enlarge it a little bit. If you look at this picture, you'll see that this actually it's starting from this point where there's an afferent artery. We have said that arteries take blood into the what? The kidneys. And so this blood, I believe you can see my cursor. Can you? Are you able to see my cursor so that we move together?
Yes.
Great. So blood comes this way. This is from the arteries, and it gets right into it gets right to the from the efferent arterial, and then it gets into the glomerulus. This is what is called, the whole of this is called renal capsule. Actually, this is just the glomerulus, the one I'm actually pointing. Hapa ndio kuna kuanga na that ultrafiltration. And then water is able to pass through this membrane. Electrolytes like sodium, potassium is able to pass, but the blood components like white blood cells cannot pass. Red blood cells can pass. Platelets, red blood cells cannot pass. Ziko kubwa sana, haiwezi pita kwa hiyo membrane, in this membrane here. So only substances that are able to pass through this membrane passes through the glomerulus membrane. Now, blood vessels like the red blood cells should not pass through that membrane. So inamaanisha mtu akiona damu kwenye haja ndogo, then there must be a problem. The glomerulus is actually having enlarged porous membranes. I mean, zimekuwa kubwa, or there is an internal bleeding, or there is an infection. Those three. There is an infection, there is an internal bleeding, and that internal bleeding can come from the reproductive system, or it can come from the renal system. And so that is a condition known as hematuria. When the filtration, when this blood passing through the glomerulus. And so from that point, the ultrafiltrated substances move this way and they go down. And so when they go down, this is what is called the descending loop of Henle. And this hii yenye inaenda juu inaitwa the ascending loop of Henle. And so in the descending, it goes like that, and then in the descending, in the ascending, like inaenda chini and then it comes up, then it follows this, and then it goes back to the collecting duct, and then it passes through, of course, either the vagina or the penis for excretion. What happens? Number one is that in this here, we have the red blood cells and other blood components. But past the glomerular kwenda huku, this other part huku yote, we only have water, toxins, and electrolytes. So it is from this efferent and the efferent ascending and descending loop of Henle where there's reabsorption of sodium, electrolytes, and all that. And then lastly, that liquid passes through the collecting duct. In the collecting duct, there's just reabsorption of water, and that is the process that happens during urine formation. Allow me ask a question whether we are together or not. Have we understood, or I should come up once again? That is just a very shallow that is a very shallow explanation of the same, but that is what our scope requires us to understand. So are we okay? Don't react, just unmute and speak. Are we okay?
Yes, we are okay.
Okay. Great. Just go and read more onto this. Don't worry. Let's proceed. So we have the proximal convoluted tubule. Of course, that one is around this place. The proximal is around this, just above the glomerular. We have the proximal, and this is where it contains actually the tubular filtrate, that which has been filtered from the glomerulus. This is the glomerulus, or from the renal capsule. Renal capsule contains the glomerulus, the Bowman's capsules, and the space there between. So hapo yote naitwa renal capsules, and I hope you can see them. Then we have the loop of Henle, the ascending and the descending. Iko hapa, hii inaenda chini alafu hii inapanda juu, and this is where this reabsorption of electrolytes. And then we have the distal convoluted tubule. Distal inamaanisha past. So this is where this is the site of action of a hormone called ADH. ADH. You know, the coordination, the reabsorption and coordination from the kidney takes place in the brain. And so there's a secondary stimulation and a primary stimulation of the same. When we are talking about the nervous system, we say that that hormones comes from the primary site, which is the brain, or the pituitary gland, and then they travel all the way to the effector or the affected organ, and in this case it is the kidneys. And so the part of the kidneys which is acted by the hormone ADH is the diastole convoluted tubule. Ni hapa. And so what happens here in the diastole, what happens, hapa tuko tu na maji na sodium na those electrolytes. So the brain will signal the kidney to absorb more water, for example, when the body is dehydrated, by producing more ADH, I believe, and then less when I think it's vice versa. Producing more ADH when there's an increased need of reabsorption of much electrolytes, and the vice versa is true. And so this is where the body actually regulates the absorption of the electrolytes and also water. So if the body is dehydrated, the body will reabsorb more water. If it's not dehydrated, it will release more water. And and that is, I believe that should be home. So I've talked about the blood supply, so I won't talk about this again. I will just proceed to reabsorption. When the reabsorption, we always reabsorb sodium, calcium, chloride ions. We reabsorb phosphorus ions, magnesium, and potassium. Let me come up again. We have potassium, magnesium, chloride ions, phosphorus ions, and calcium. So those are what are reabsorbed into the body. Those are what are reabsorbed. I mean, any other thing can be reabsorbed depending on the amount the body is actually experiencing. And that is sodium reabsorption. I won't talk about it in details. I won't talk about sodium in details. So let's go to the ureters. And I know we have appreciated it from the previous slide. So we have these are just two muscular tubes, about 25 to 30 centimeters peke yake. But they're quite large, about 25 to 30. And they are connecting the kidney to the bladder. And after knowing that, that is all about what you need to know, because you also understand that the medium of the ureters are um, are um, are helping to transport urine. And where is it transporting urine from? It's transporting urine from the kidneys to the bladder, and that is all. So so that is all about the ureters, and you can see it's the orientation over there. You can see orientation over there. Let me ask you a question. Is urine acidic or basic? Someone ask this, answer this question. Yes. Yes, someone carry that there.
I believe it's acidic.
Yeah, it is acidic. Do you know the pH, the exact pH?
So I had a question. So does the presence of ammonia make it acidic with it being base? It's acidic because of the waste.
Actually, the a normal urine should have its pH ranging from around 4.5 to 8. So inamaanisha urine can be basic, but it can also be acidic. But averagely, it should be slightly acidic. But this is actually dependent on several things like diet, hydration, and so much. So what happens is that when you have a very acidic urine, either this person can be on drug like aspirin does this, and this makes the body want to excrete it quite faster. Ammonia is a basic substance, so haiwezi ikaitoa from the acidic completely and turn it to a basic substance. Actually, ammonia will form some CO2, which with time will be able to turn even the longer it stay, I mean, it will be able to turn it to an acidic substance, because CO2 it will form carbonic acid in the in the kidneys, in the bladder, sorry, in the bladder. So that answers your question. Sasa mtu akikunywa maji mingi sana, it can even be having a pH of 7 or even 8 and all that. So that is what I would say. Are you answered?
Yes.
Okay, let's proceed. So let's proceed now. So controls of urination is actually happening from the brain. I've been able to explain this. But there is a pressure. There's a pressure that only comes about when there's a certain volume of the accumulation of urine in the bladder. Now, this pressure should be constant up to the age of about 35. And ukitaka kujua kwamba a male figure has either a bladder issue or a prostate issue, you actually assess the far they can I wanted to say the far they can project their urine while urinating, but that is exactly what I'm saying. The speed at which their urine comes out with, so that wakiwa vijana watasimama hapa and they are able to project it maybe 1 meter away. But anyone who goes beyond 50 centimeters is actually developing or experiencing a problem. Beyond 50 centimeters, there must be a problem. Whether 777, 177, or 777 of age, which is not possible. So one of the ways to tell that male actually have
below,
and this is
below or above?
Yes.
Below or above 50
Yes.
centimeter?
I didn't get you well.
Is it below 50 centimeter or above?
It should be above. It should be more than 50 centimeters. Yeah. Just get that right. It should be above 50 centimeters from age 35 kuendelea, lakini hao vijana wadogo wanafaa kuenda hata 1 meter, wengine wanaendanga hata 2 meters. That is just okay. So this is from a rooted position of the ground. I mean, they're not in an elevated point. So and so let's proceed. So the control of urination is just by reflex. And I have said that this may, if you see such a clinical presentation, it may either detect that there is a problem with the prostate. We'll talk about benign prostatic hyperplasia, that is enlarged prostate, on Thursday, and also prostatitis. But the idea here is, if this happens, then there must be a problem with either the bladder, or there is a problem with the prostate gland. There is a problem with the prostate gland. But above 80, you can now actually overrule all that. Now, nice. Let's proceed. The urethra, of course, you know what urethra is. Urethra is the part that it's just a tube leading the urine out of the body, and it's about 20 centimeters, by the way. And this passes through the prostate gland. It passes through the prostate and also through the penis. So what happens is that during ejaculation, because it passes through the prostate, the process gives out semen, which actually facilitates the sperms to have their way out. And it's not really important in the urinary tract or the urinary system. But I will talk about prostate on Thursday and how to treat prostatitis. Max will talk about how to treat prostate cancer on Sunday, I believe. But I will talk about how to treat prostatitis and benign prostatic hyperplasia, that is enlarged prostate. large process. So let's proceed. So that is the urethra for you. And in women, the urethra is quite short. This explains, by the way, why there's a lot of urinary tract infections in ladies than in men, because men has a long urethra than the lady than the female, and this is how it affects the concentration of microorganism in a shorter tube is much more than in a longer tube. And in long tubes, they are more exposed to macrophages, those are the white blood cells, and the medium there is also not very favorable, and so they are able to be dealt with quite quite faster. But for female, this is not very possible. So what I'm trying to say, and another reason is that most bacteria um, are actually loving their acidic environment than basic environment. We said the other day, sorry, that we said that your body should be slightly alkaline, lakini ikikuwa basic, ikikuwa acidic, then the most bacteria will survive in that. So if you look at the urinary tract system, majorly from the vagina and part of the urethra, in for female, you'll get that it is slightly acidic, and this promotes the habitation of some bacteria, if not most. I was just trying to explain why there's more urinary tract infections in ladies than in men. So I believe you've understood that concept. So let's proceed. I want us to now get into these infections. What are these urinary tract infections, and how can we diagnose them, and how can we just understand them? But before I proceed, any question on anatomy and physiology? Any question on anatomy and physiology? Are we okay? If we are okay, just give me a thumbs up so that I move to infections. Are we okay? Brenda says we are together. Uh, Great. So even for this system, I believe mimi niliwapea ile ni take away exams ya musculoskeletal. I'm looking forward to get a very comprehensive responses from you on Sunday. And I will also give you a takeaway cut on the urinary tract system. Ama mnataka nini? Mnataka exams so that we have it on Sunday. Do you want a takeaway or you want an exam? Well, silence means that you don't want either of them. Utasema tu
Mwalimu, did you give us an exam take away?
I gave an exam. I gave a takeaway.
When?
It was actually a poorly done takeaway exam on the treatment plan for arthritis. So that is the exam, and it will be marked out of 30. So I really expect a very comprehensive treatment plan that will give you 30 marks. Sasa unajua nikiwapea takeaway, I expect you guys to get everything 30 over 30. Let's proceed. Redemptor, si tuko pamoja?
It's okay.
Yeah, there's no any other exam we give out. So let's proceed. I want us to stop sharing and then I share again. Stop presenting. Then you present again. It's not that one. So it's not that one. Now we want to proceed by understanding the infection of the urinary tract system. And so I want to welcome us on board. I know you have you have actually appreciated this at some point. The lower urinary, no, I will talk about the lower and then I will talk about the upper urinary tract infections. So let's start with no. What do you understand by the term urinary tract infection? What do you understand by the term urinary tract infection? Yes, anyone?
What it says.
Yes, what is it?
I'm saying it's just as it says. It is referring to the infections of the urinary tract.
Yeah, so I want you to just make me understand what are infections and which part of the body is this. I want you to be specific. This is a common broad spectrum term.
Okay. That's the areas of the urethra.
Yes.
And urethra and the like.
Good. Anyone else? Well, so let's proceed. So infections, of course, you understand, as she said, just the way it is. Just the way it is. It's the lower urinary, and when you talk about the lower urinary, you are actually referring to the bladder and the urethra, or rather, actually ni hizo mbili tu peke yake. An infection is an attack to the body, either viral, bacterial, or a fungal infection. And so we have the two classifications, the lower and the lower urinary tract infection and the upper. But do we have any idea on on the name of this bacteria and fungi that causes, and viruses and fungi that causes the lower urinary tract infections, or any type of infection that you know?
In men or in women?
In both. Just tackle both.
Are you asking about men? I'm about.
I'm asking about both.
Yeast infection.
Yes, yeast infection is one of them. But you know, if gonorrhea. Okay.
We have candidiasis.
Candidiasis, very okay. Gonorrhea is usually classified as STI. Any other?
What about chlamydia?
Chlamydia, trachomatis is there.
We have bacterial vaginosis.
Bacterial vaginosis is there. Thank you. Kumbe mnajua hizi vitu. Now we can proceed. At least, so when you talk about urinary tract infections, this is just a term that is applied to a variety of clinical conditions, which is ranging from cystitis. Cystitis is actually, what is cystitis? This is when the bacteria has actually invaded the bladder. Then it's called cystitis. Cystitis. Then this can actually affect the urethra, inaitwa urethritis. It can also affect what? It can also affect, of course, we've not talked about the upper. So those two organs, cystitis and urethritis. Cystitis means that the bacteria has affected the bladder. Urethritis means that the bacteria has specifically affected the urethra. So, nice. Let's proceed. So, UTI is classified as lower and upper, and the lower mostly are known as cystitis, but also there's also urethritis there. Upper are called pyelonephritis. Pyelonephritis means that it has actually affected the upper urinary tract, which are just the kidneys and majorly the kidneys, maybe in a urethra, not urethra, ureter. Like if you have a kidney, there's high chances that every urinary tract infection that are actually in the kidneys, then I'm saying there's high chances that any urinary tract infections in the kidneys have spread to the lower respiratory tract. About 50% of women will have UTI during their lifestyle. It can be a recurrent
Mwalimu,
or just a lifetime, like once in a lifetime.
Mwalimu.
And this
Hello,
age
Mwalimu.
actually, yes.
Your screen is iko tu mahali pamoja.
Okay.
Ilikuwa
So
tu katika page ya kwanza.
if I don't reset it, these are the problem with using this is the definition of UTI. This is the far I've gone to. This is the definition of UTI. Urinary tract infection is a term that is applied to a variety of clinical conditions ranging from cystitis to severe infections in the kidney with resultant sepsis. Sepsis is a severe infection. Sepsis is a severe infection. Inaitwa bacterial or viral sepsis, vitu kama hizo. So what happens is that UTI is divided into the lower urinary tract infections, which are called cystitis, and then the upper urinary tract infection, which is called pyelonephritis. So I believe we are together up to there. Are we?
Yes, we are together.
Yeah.
Great. Thank you so much. So further classification, we have isolated UTI, which is a single episode UTI. Then we have recurrent, which is majorly caused by fungal yeast, hizo candidiasis, hizo sasa. So at one time happens maybe just one and it takes like 2 weeks even imeisha. But a recurrent UTI is one which takes more than two infection in a period of 6 months or within 12 months. That is a recurrent UTI. This is not a joke in the present world, and specifically I'm referring to Nairobi. It's not, and I realize that most women actually work on a UTI, and I will tell you the cause today so that you'll be able to understand why all this happens. So we have the predisposing causes of urinary tract infections. What is it that is disposing you to this? Number one, incomplete emptying of the bowel. And when you incompletely empty the bowel, of course, the remaining waste must have a little bit of, and this is common to men, by the way, and even to women. Then the incomplete waste is actually having
is 21 hours.
How is it called? Some bacteria in it. This may be as a result of bladder obstruction. Kuna kitu imeifunga ama imekuwa narrow at some point ama ni uzee, so that pressure is not really coming out as it should be. And then bladder diverticum, and then we have neurogenic bladder. I mean, all these things are explaining why people would have incomplete emptying of the bladder. There's either a neurogenic complication, or there's a physical obstruction, or there is maybe something like cancer or just an abnormal growth along that lining. And that abnormal growth can be calculus, a foreign body just growing around the, like the kidney stones, But kidney stones will only affect the urethra, the bladder, sorry, if it has grown to an extent that it's able to press it or something like that. So then we have pregnancy associated obstructions, and also dilation problems, so that some people cannot really fully have their urethra dilate as it's required to have. So in short, I've talked about physical obstruction, I've talked about foreign body growth, or any malignant growth, cancer, there can be an infection where there is inflammation. We say that infection causes inflammation, and this may actually hinder the passage of urine. And this little amount that is remaining has bacteria. This bacteria can multiply over time within a very short time and outgrow. This is what causes urinary tract. This is one of them. Number two is about estrogen deficiency, which can give rise to lowered local resistance of, in this resistance, we are actually referring to the physical, the ability of the body to expel, or number two, resistance in terms of immunity to clear those bacteria. Then we have colonization of the perineal skin by strains of E. coli. Actually, Escherichia coli, this is a bacteria that is a normal flora. Nikisema normal flora inamaanisha inaweza kaa tu hapo na isilete ugonjwa. So E. coli is a normal flora of the gut. It's a normal flora of the stomach. But it's the thin line. It has a very thin line between being a normal flora of the urinary tract, so that an outgrowth to hivi kidogo of E. coli italeta infection. And this infection can bring about diabetes, immunosuppression, but this takes time. What I'm trying to tell you today, that ukienda OC na wapime E. coli, wapate E. coli iko kwa stool, kwa urine, and it's not contaminated, the urine is not contaminated, then this indicates an infection. Of course, I'll tell you other bacteria that indicates infection. So we're talking about acute cystitis. Cystitis. This is where this is acute, means like this is sudden, all of a sudden, where someone is having an urinary tract infections, and it has happened just for the first time and very rapidly within 1 day or so, and its diagnosis are actually made clinically. So before I proceed, how would you know that you have acute cystitis? Like, what are some of the clinical symptoms that will come? Or let me just talk about general UTI. How do you guys know that you have UTI? What are some of the clinical symptoms of any type of urinary tract infection? Yes, just speak out. Don't carry up your hand.
Burning sensation when urinating.
Yeah, thank you. Burning sensation during urination, and sometimes it's actually very painful. Yes. Any other?
Itching.
Itching, mostly in the urethra. Yes. Any other?
Abdominal pain.
Lower abdominal pain, and these are the extreme lower abdominal pains. Yes. Any other?
Frequent urination.
Frequent urination. Well, not very, but the body will actually adjust, and you may or may not frequently urinate. Yeah, thank you. Any other?
Discharge.
Yeah, discharge. There's a past discharge. Actually, we were reading something on Sunday with Denzel when we were coming there, and we realized that passing out of discharge indicates that your body is either having a very strong immunity or a weak immunity, because the cells that are destroyed, the cells that are destroyed by bacteria, are actually destroyed further to produce pus, so that the body can actually remove them out of the body. So discharge is one of them, one of the clinical indicators of urinary tract infections. Which one else are we forgetting?
Urine with a foul smell.
Yeah, foul smell urine, especially for bacterial infection, and even candidiasis, though not very much. Any other? What about the color of the urine? I taught you this the other time. What does the color of urine tells us about urinary tract infections?
I would think most of the times inatoka na pus. Ukiangalia urine utapata iko na vitu zinakaa mucus.
Yeah, presence of pus cells, which are actually not just identified visually, I mean, with the naked eyes. This is only confirmed by through a microscopic view. So, pus. So, I want us to proceed. I will give you all the signs. Let's just proceed. So these are the presentation. And we said that 50% of women will have an episode of cystitis in their lifestyle. I mean, lazima tu at some point, because they're very sensitive. But there's a frequent voiding of small volumes. Dysuria inamaanisha burning, this burning. And urgency, suprapubic pain, like nikitu, well, urgency inamaanisha it's able to it's something that it's just coming when you're not prepared to receive it. And then we have the suprapubic pains. Then we have hematuria. Hematuria is blood in the urine. Blood in the urine. These are some of the typical clinical features of the lower urinary tract. And sometimes you may experience cloudy urine. Actually, don't say urine with pus, just say cloudy urine because you are not sure what is actually there. But pus is one of the of the of the of what is present. And then we have other signs which are not included here, like chills, fever, and what chills and fever majorly. And when there's an ascent, when there is some foul smell and it's really intense, then this actually, in most cases, indicates that this infection has reached the kidneys. It has reached the kidneys. What brings about that effect is the passes or the long time it has taken for the process of ultrafiltration and the, the filtrate taking too long in the bladder. So this is what brings about the foul smell, the foul smell, the foul smell. Let's proceed. So how do you investigate? How do you investigate? And let me just hear this from you. Let me hear from you. What would you do to just ascertain that this person are actually undergoing a urinary tract infection? What will you do? How will you confirm your diagnosis? Yes, let me hear from you.
Lab tests.
Yes, ukisema lab test unasema specific lab test. Thank you for that. So thank you for the lab test. Which specific lab test will we do to confirm that someone is having all this condition? And this is not in my slide, so just write it down. But let me get your responses. Which specific lab test will you do?
Urinalysis. Analysis of the urine. I'm calling it urinalysis. I don't know what it's called.
Well, I had urinalysis. Urine analysis. Urinalysis. It's urine analysis or urinalysis. Thank you so much. So we'll do urinalysis. Urinalysis actually, ita-confirm vitu nyingi sana. Number one, it will confirm whether there's blood in the urine. Number two, it will confirm whether there's sparse cells in the urine. It will confirm whether there's sparse cells, a specific gravity. It will confirm the pH. Actually, the pH will tell us whether we are suspecting an infection or not. It will confirm glucose. It will also confirm nimeongelea parcels and all that. So this is very important. This is very important, and it will be able to show. So apart from the blood, apart from urine analysis, what else would we do?
Well, the doctor may have to do a physical exam.
Physical examination, yeah, that is true. Where, but there's usually very minimal finding in the physical examination for this. Where sometimes we just check for the suprapubic tenderness, which is really not a very comprehensive way of doing this. And hizo zingine hata si necessary, so I don't want to say them. Yeah, thank you. Someone to talk to me about blood test and refer to the white blood cells. In case of an infection, white blood cells zitaenda chini ama zitaenda juu? Someone to try? Remember, we are also in class, we are learning, so just write notes.
Chini.
Itaenda chini.
White blood cells will be more.
I sincerely didn't get you. Come up again.
I'm saying
Yes.
White blood zitakuwa juu. White blood cells.
Well. Mtu anasema zitakuwa chini, mwingine anasema zitakuwa juu. Sasa wacha tu vote ndio majority rule hapa. Nataka kila mtu a vote ndio nione response zenu. Laptop ishakata. Nimekata ku and to see. How many says that the white blood cells will reduce? How many says the white blood cells will reduce?
all of us.
Jane, that is not the response. There's no response like all of us. How many says that the white blood cells will go down? Just carry up your hand. You carry up your hand like this. Yeah. Ruth Mora says it will go down. Nani tena? Ruth Redemptor. Na tulisema white blood cells ndio tunatumia fight infections. So in a case of urinary tract infections, are they going to go up or down? So we have Winnie Odhiambo, we have Redemptor and Ruth Mora. Good. How many says that they will, so lower your hands, they will go up? Na pia anasema they will go up. Ruth Mora bado anasema they will go. Okay, nice. 3 more. Sasa the majority wins. The white blood cells will go up. Jane, ulisema all of us na sasa unakari unabeba mikono.
Mwalimu, I thought ulikuwa unasema zenye zitaenda up. Sikuelewa hiyo swali vizuri. It should be up.
Siyo ndio nimesema. Sawa. So the correct answer, so that we save time, is that zitaenda juu, zita increase. The white blood cells count will increase. And when you talk about the white blood cell count, they will increase because the body is trying to defend back. There is an infection. The brain signals the bone marrow to produce more white blood cells, just to be able to reduce the bacteria and the viral and all that overload. And so the white blood cells itaenda juu in this case. So for the blood, we can do what is called complete CBC, complete blood cell count. It was CBC. Let me share my screen again. It was CBC, complete blood cell count. Ama inaitwa nini tena? What is the other name? Fellow doctors, what is the other name of CBC?
Can I try? Is it hemoglobin count?
It's not hemoglobin count. Hemoglobin is just part of the complete blood cell count.
Blood culture?
Okay, nice. It's not blood culture. It's not blood culture. Complete blood cell count yenye tunafanya platelets, white blood cells, red blood cells na kila kitu. Lakini tuna focus more on the white blood cell.
Inaitwa nini? BS or something.
Yes? Umesema RBS?
Something to that effect.
Penye mmefika hapa naona tutafanya another 3 months.
Total blood count.
Yeah, that is what I was looking for. Unajua saa zingine mnaweza sema majibu hadi mwalimu akwe na njaa. Complete blood count ama total blood count. Hiyo ndio tunafanya. So there are other tests that you can do. You can actually, someone talked about urine culture and sensitivity. You can write that. All this is not in my slides, but you just note them down. I think I've overlooked that when I was preparing all this, but you can just include that. So I was saying that we can do what is called urine analysis, white blood cells in the urine. That is white blood cells count. Hematuria, hiyo white blood cells count in the urine ikikuwa mingi, inamaanisha there may be infection. Hematuria, blood in urine. So if this blood in the urine, this can indicate infection in the lower or upper urinary tract, but majorly upper. Then urine culture is required to confirm the diagnosis and identify the causative organism. Inamaanisha after doing, for example, urine analysis na umepata white blood cells iko juu ama white blood cells iko juu ama umefanya a specific test, for example umefanya E. coli test peke yake na umepata this well, this is an antigen for E. coli, then you'll do what is called culture and sensitivity. Culture is just taking that sample, ni kama urine, and you put it in a media. A media inaweza kuwa kama blood agar, something like that. Alafu inakuwa grown up for like 24 hours, and then wanaenda wanapima, wana confirm with those confirmatory tests, and then they are able to tell which specific bacteria is this person suffering from. Alafu after that ndio sasa wanaenda for sensitivity. Sensitivity test ni test tu ya antimicrobial, antibiotic. Sasa wanachukua antibiotics mingi wanaweka in the same agar, and then they introduce the pathogen na wana observe the growth where there's no growth near the antibiotic used, is where they will actually focus on, so that for an antibiotic which will record no growth, inamaanisha hiyo antibiotic inaweza tibu. And so that is where plant-based medicine, herbal medicine comes about, because herbal medicine is broad spectrum in all nature. So inamaanisha itafagia kila kitu. But of course you have to know what you're using. I believe you've understood. Have you? Kuna mtu aliniambia huwa nafunza haraka, so that is why I want to just confirm that we are together. Are we together? Are we together?
Yeah.
Great. If you're together, that is okay. Let's proceed. Sometimes, by the way, let me give you my experience. There was a lady. She told me that she was diagnosed with the upper urinary tract infections. And so, mimi na kerere yangu, I didn't even take in-depth history about it. I just gave her antibiotics just straight away. Nikampatia diuretics, antibiotics, and then nikampatia immune boosters. So I am wondering, because I gave her an extract of the same, and it was really very powerful, where like it was really very powerful. And then 1 week later, she's not recovering at all. She's not recovering. 1.5, she's not recovering. And then something tells me I should consult with my fellow doctors why this may be happening. Consulting with them, they're like, wow, you have given the best combination, Elisha. I don't see why this is not working. And when I reach out to one of the specialists in urology, the specialist tells me, advise that patients to go and do a scanning. I mean, an ultrasound. With the scan, it showed that she had a cyst in the ovaries and not this was not a urinary tract disorder. I mean, this scenario actually taught me that reproductive complications are actually more confused with the urinary tract, and vice versa is also true. So before you actually land on the specific type of treatment, please be sure of the diagnosis. Be very sure, because when we are now handling the ovarian cyst, it was 2 weeks into the meds. She'd spent a lot of money on the same, but it was the doctor's neglect to take good history of the same. So the only assurance of a diagnosis is a lab test or a clinical affirmation. I mean, with the symptoms and all that. So mostly mtu akiumwa na kidney anaisikia kwa mgongo, but mtu akiumwa na ovaries na hizo the ovaries and all that huwa anaisikia from the sides ama from the front part of it. That is what brings the difference. And so mimi sikuchukua history and we can now proceed. Now, so I was giving you the aspect of radiographic imaging, where we have ultrasound, we have MRI, we have, depending on what you want to diagnose. Of course, MRI is the more detailed one. And we also have AI scanning. And there's also a machine called the quantum scanning machine. It's actually a very good one to just tell you the general functioning. So that is it. From here, sasa ni madawa. This is honeymoon cystatitis. This is where there's an infection from just because there was an intercourse and there was no sterility. That is honeymoon cystitis. This is part of the acute cystitis that you can actually have. Now, let me put things into context, because I believe that with this course, sometimes someone will come to you and you'll direct them back to the hospital to do the diagnosis, and when they come back, you will literally shine in lab treatment, because the course is not very much in depth to tell us how to do the diagnosis properly. And so when I talk of management, I need to know the exact cause. Number 2, I need to know the mechanism of action that I will approach the treatment regime or plan with. And number 3, I need to know the side effects of the treatment plan I am actually subscribing myself into. So I want to give you an example. That someone comes with a bacterial reinfection. Unajua tunakuanga na infection na tunakuanga na reinfection. Reinfection actually happens when for example you had candidiasis and you didn't clear every strain of candidiasis, so kuna zingine zilibaki and then zika overload the system once again. Or you are infected by another bacteria, and then after some time, you're reinfected again with another strain or another species of bacteria. And so that is reinfection. Majorly, about 60% of the reinfection happens when just because of the yeast or fungal infection. And here is where Candida albicans comes in handily. But there it is very hard to manage it. Very hard to manage it. And so having said that, I can see it's 9:30. I do not want to extend. I will start from there. Our next class will talk about the herbal treatment and of course, just understanding the remaining part of the diseases of the urinary tract infection. But before I leave, I will do a really big disgrace if I will not tell you this. I will do a very big mistake if I do not tell you this. Just a minute. Any question? Is there any question as I? Any question?
I have a question.
Yes.
Can someone be infected by multiple infections at the same time?
What do you think of that question?
I'm asking because I have a friend mwenye alikuwa na infection but alipewa like alipewa antibiotics mingi of different kinds.
Yeah. Mute. Great. So someone can be infected by actually with more bacteria as more as possible, because bacteria itambui ati sasa E. coli ishakwa infest, sasa candida ichill tu isikuje, or juu candida sasa ishakuja na E. coli watakuwa wengi, sasa maybe chlamydia trachomatis isikuje. That is the mindset of human beings. It's not the mindset of microorganism. And so with the lab cultures, we actually isolate up to 5 bacteria at the same time. But of course, this will depend with the environment, so that there are bacteria which can survive more on specific environment than the other. So the answer is yes. They were given such bacteria, such antibiotics for 3 reasons. One, because maybe the clinician is not very sure of which specific infection is actually dealing with. I mean, labda amefanya tu urine analysis peke yake. Now with the urine analysis ameona kwamba there is high level of white blood cells, and so it doesn't know whether these bacteria or viruses are the ones that you can attack the treatment from, maybe the cell membrane, ama the nucleus, ama ikwe the coating, ama such. I mean, every antibiotic has a specific activity on the microorganism. For example, there's a membrane called beta-lactam. That's all the antibiotics in that category, it attack to beta-lactam membrane peke yake. Beta-lactam peke yake. Yeah, sorry for that. And so what happens is that that is why they'll give a broad spectrum antibiotics ama antibiotics mingi yenye ina address all that at the same time. So I believe that answers your question. Just because of non-specific diagnosis ama a broad spectrum antibiotics which is able to clear a wide range of diseases or infections. So having said that, I will stop there. I have another meeting right now. Someone is really calling me. So we'll coordinate from there. I want us to pray. For the pending questions, kindly let's carry them forward to next class. Next class. You'll just bear with me for today. I'm the chair of the other meeting and they are really calling me. So let's have a word of prayer from Jane Agano.
Let us pray. Our loving Master, who is above, thank you for your care. Thank you, Lord, for the lessons that you have learned. Thank you for making it easy for us to understand. I pray, Lord, that for those who have not understood, you may give them the inner wisdom to understand next time. Pray for our teacher. Give him courage and the wisdom to continue teaching us. And I pray that you take care of us until we meet again next time. It is my humble prayer through Jesus' name. Amen.
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 Okay, have a good night.